Hello, I'm Cheryl Checkers. Welcome to my presentation, Navigating a Later Diagnosis of Autism Spectrum Disorder in Female Adolescents and Young Adults with Autism Spectrum Disorder in the Clinical Setting. You may have viewed my previous presentation on navigating a later diagnosis for females that was more focused towards parents. Today, I'm back to talk about supporting females in the clinical setting. I wanted to give a huge thank you to FAU CARD and to PEPSA for allowing me to present on this important topic and for having me back. A little bit about FAU CARD before I get started. FAU CARD is funded by the Florida legislature through a discretionary grant from the Florida Department of Education. They provide all free supports that include expert consulting, training, and support. One-on-one consultation with families, school observations, technical assistance for families and schools, safety information and resources, and referrals to community provider agencies, also trainings on evidence-based practices. FAU CARD supports 5 counties: Indian River, St. Lucie, Martin, Okeechobee, and Palm Beach. They have office locations in St. Lucie and 2 locations in Palm Beach County, Jupiter, and in Boca Raton. You have all the numbers here for all their different offices. How professionals can connect families to FAU CARD. So any documentation of an autism diagnosis or eligibility, doctor's prescription given to family recommending referral to FAU CARD. Also, school staff can share FAU CARD consent forms with families at eligibility meetings, at IEP meetings, that clinicians can pick up at the schools. School staff can assist parents to complete on the website a request for an appointment. Directly on the website at www.autism.fau.edu. Clinicians are assigned based on the family's home zip code. A group intake card overview for parents at school via Zoom is available, or one-on-one intake meeting with parent and at school via Zoom as well. A little bit about me before I get started. I'm a licensed mental health counselor and a national board certified counselor in private practice, where I specialize in helping adolescents and adults with autism spectrum disorder and usually a co-occurring mental health diagnoses. Also, I support family members and parents and caretakers, also provide professional consultation. I'm a clinical consultant for FAU CARD. My past experience includes working as a clinical support specialist for FAU CARD and a clinical director for the National Alliance on Mental Illness of Palm Beach County. I received my master's degree in psychology and mental health counseling from Nova Southeastern University. I have advanced clinical certifications in autism, anxiety, trauma, and ADHD. And I proudly serve as president of the board for National Alliance on Mental Illness of Palm Beach County. I always like to talk a little bit about language and the first person versus identity first language. There has been such a resurgence of the identity first language, which is autistic individual or autistic female. And this term is used as a form of pride among many individuals with autism to mean autism is more part of their identity. Others continue to prefer to use person first language, which is absolutely fine. I use both terms interchangeably in the presentation today and also outside my presentation. I wanted to mention also the term neurodivergent is becoming much more popular. The concept of neurodiversity, recognizing that both brain function and behavioral traits are simply indicators of how diverse we all are. ADHD, dyslexia, autism are all examples of neurodivergence. Also, I will be using the terms females, girls, and women broadly throughout my presentation. It is important to note that before I get too much into that, I did want to say, add that it is important to note that it's best to check what term your client feels most comfortable with, whether it's person first or neurodivergent or autistic. It is especially important with adolescents and young adult females you may work with, because making a sense of a later diagnosis is really difficult, especially for that age group. And some clients might not even be ready to accept the diagnosis and may have difficulty with any terminology that's used. Okay, so on to the use of the term female and girls. I use this based on biological differences in the research of females and males with autism spectrum disorder. I acknowledge there is much more involved in gender, including individual differences, and I'm using the term female very broadly. I also feel it's really super important not to mention that males can also have many of the challenges and kind of that different phenotype challenges that I'm going to be talking about today. They may exhibit ASD and what I view as this emerging and broader female phenotype. So it's important not to swing too far in the opposite direction of the extreme male brain that I'm going to mention later, and create a female specific profile that excludes males. So many of my male clients do fit within this emerging phenotype, and oftentimes also end up getting a later diagnosis. Purpose of my presentation. The purpose of my presentation today is threefold. It is meant to provide information and tools to help mental health professionals and clinicians better understand females with autism spectrum disorder. And my hope is that you will take away tools you can immediately incorporate into your practice. It is also intended to help put autism on clinicians' radar and mental health providers' radar, so that when you're sitting across from a female in your practice, that you're at least thinking about this, because it does look so differently. And many females seek therapy, yet their autism is often overlooked, which I'm going to talk a lot about today. Or they're misdiagnosed with other mental health conditions, or both. So it's difficult because as clinicians, we weren't trained in this female phenotype when we were in our graduate programs. And really, even today, there's still little information comparatively speaking about females. So it is one of my main goals to make sure that that clinicians and mental health providers do consider autism when they're sitting across from their female clients and who may be exhibiting many of the characteristics I'll be talking about today. My presentation is also meant to share many of the components that I have found helpful in working with my female clients and their families. Certainly this is personal experience I'm sharing, and it's not going to work for everyone, but I do hope that you'll be able to take some helpful pieces away that you can put into practice right away. So let's start off with talking about what does autism spectrum disorder even look like. So the word spectrum always comes up, this oftentimes these graphics portray what we think of when we think of a spectrum. So a lot of people think of spectrum as being this horizontal line that runs from low functioning to high functioning, and that people either have a little bit of autism or they have a lot of autism. Also, we kind of think of like the word spectrum brings to mind like everybody fits somewhere on that spectrum. And really that's not how autism spectrum disorder looks. Some of the newer graphics that are coming out, these wheels, depict autism spectrum disorder much better. So these wheels acknowledge that the spectrum isn't the line going from a little autistic to very autistic. It's more of a spectrum of characteristics that most people on the spectrum have, but to varying degrees. It also respects that everyone is different and therefore may have difficulty functioning in some ways and not so much in others. So, you know, what's depicted here in this chart or this wheel includes depression, fixations, abnormal or flat speech, sensitivities, social difficulties, anxiety, which is a big part of having autism, for eye contact, tics and fidgets, aggression, so many different considerations here. And then, you know, the gradations, as you can see depicted in the actual people here, they show the degree of difficulty can be much different in each person. For instance, someone might score a 10 out of 10 in terms of anxiety and meltdowns, and 3 out of 10 in terms of sensory processing. While another person might score the reverse. They might score 3 out of 10 in anxiety and meltdowns and 10 out of 10 in sensory processing difficulties. So why are we missing girls and women with autism? So research shows that the male to female ratio is between 4 to 1, and some put it at 3 to 1, with the largest recent research study placing this number more at 3 boys to 1 girl. Also, there appears to be a diagnostic gender bias, meaning girls who meet criteria for ASD may not receive a clinical diagnosis. And so this extreme male brain theory informs how many of us view autism, and going back to, well, what did we learn in graduate school, or what did we even learn on our own, you know, outside of our graduate school? And this Simon Baron-Cohen, who came up with the extreme male brain theory, really informed how we view this. And, you know, thinking about like the male behaviors, acting out behaviors, and the you know, so many other things that may come to mind for us that don't fit this female phenotype. In addition, you know, much of the research further shows us that extrapolating this largely male model of autism to women and girls is very problematic, and that, you know, we're missing our females because of it. They don't, oftentimes females don't fit in that stereotype, and sometimes even the males don't fit in that extreme male brain phenotype. Masking and camouflaging to hide autistic characteristics is another reason that we can miss females. So again, thinking of that extreme male brain theory, thinking about the repetitive behaviors, like maybe, you know, flapping arms or spinning, or also the different social communication difficulties. Women, females, girls and women oftentimes internalize. So we don't see a lot of behaviors. They're acting in rather than out. So again, we'll miss that because we don't see it as a red flag. Some more reasons: the coexistence of multiple disorders such as ADHD, anxiety, depression, OCD. This is very common. A lot of the females I see in my practice, you know, come to me with a whole laundry list of diagnoses, but not the autism diagnoses. So it makes it very difficult. There's a lot of crossover with a lot of the symptoms between these different diagnoses, and so it makes it very difficult. Females might exhibit what we refer to as a milder presentation, and may often be viewed as more of like a deterioration in skills or social competencies as they get, maybe into middle school or to high school. Females may exhibit interests that are considered typical. I'm going to be talking a lot about this in my presentation today, because this is so important to have on our radar as clinicians and mental health clinicians, our providers, because oftentimes females can have an interest in things like Barbies or things, we'll kind of look at our assessments and the way we assess or do our clinical interviews, and it won't throw a red flag that because we think, okay, it's not what we know as what we've been taught, as more of the typical comes to mind: trucks, cars, things like that. So I will be talking more about that. Also, our autism assessments are not always representative of the female phenotype, and even our gold standard assessments. And so these oftentimes won't provide an accurate diagnosis unless we're able to kind of look at, or at least we have, the education and the information on the female phenotype to view it through that lens when we're diagnosing. And I'm going to talk more about that as well. Also, clinicians just don't have it on the radar. Females may not seem at all, fit within our view of what autism is. So they oftentimes get a mental health diagnosis such as borderline personality or bipolar disorder, among other diagnoses. So the late diagnosis, and I wanted to talk a little bit about that because, of course, this what I'm focused on today is adolescents and young adult females, because that is often when the diagnosis comes for females. It's often diagnosed after females are reaching out for support for other things like anxiety and oftentimes depression. Eating disorders are very prevalent among other mental health conditions. So oftentimes the ASD may go unnoticed until they're reaching or approaching puberty, and may demonstrate more difficulty coping with changes, or have oftentimes I'll have my families tell me, that their daughter is very moody or having difficulty with emotions. That usually is brought on by puberty. Also, as I mentioned earlier, the middle school and high school, when things become more difficult to navigate, that's oftentimes when then it's considered, because the teens' social world becomes a little more difficult. If you think about families planning social activities for their daughters, when they're in elementary school and sometimes into middle school, and then all of a sudden it switches, and then the adolescent has to plan these things on their own. That oftentimes then they can't navigate it, so that throws a red flag, and then we may then consider doing an autism diagnosis. Also, a lot of my females have already questioned autism. They'll tell me they've always felt odd or different, and they'll actually explore, like they'll do research online, they'll take self-assessments. They will either say to me they're not surprised if I bring it up, or they'll even be the first to bring it up. And so that, that's another thing, that it's different, and sometimes it's a challenge and for them to even consider, what does even autism mean to an adolescent or a young adult that's just getting a diagnosis. But others, they have friends that have it, or they have done their research. So important to note that sometimes happens as well. And also, sadly, diagnosis comes oftentimes after a mental health crisis or hospitalization, especially with our females. By age 25, 20% of females with autism and only 11% of males, which is still a large number, have been hospitalized due to mental health difficulties, compared to less than 4% among people without autism. And this was discovered in a very large research study that was just released in 2022, and it included 1.3 million individuals with autism. So they looked at both females and males, and they determined that they were 3 times more likely to receive a psychiatric diagnosis compared to someone without autism. That was, and they compared the same sex as well. So, so girls to girls and males to males, still 3 times higher to even have a mental health diagnosis. And then the risk was even extremely higher for females with autism. So this clearly this research emphasizes the need, the pressing need really, to address the mental health needs of both females and males with autism spectrum disorder. All right, I have mentioned several reasons why females go undiagnosed or misdiagnosed, and I talked a little bit about the several barriers to diagnosis and not being on a radar as clinicians when it comes to females, and maybe even our autism assessments not always picking up female presentation of autism. In addition, clinicians may view the DSM criteria through a male lens, and then that's another barrier to diagnosing females, since they may not be seen as fitting this criteria for an autism diagnosis. And for all these reasons, I feel is really super important to understand how to view the DSM-5 the criteria through this female lens. And in the next few slides, I'm going to be walking you through each of the 3 categories of the DSM-5 impairment and how these may appear very differently in our females. The 3 categories I'm going to be talking about are social deficits, communication deficits, and restricted and repetitive behavior. The first category we're talking about is social deficits. In the DSM, this is referred to as persistent deficits in social communication and social interaction across multiple contexts. Impairment for females looks so much different in this category. So females, girls, women, adolescents, they're oftentimes referred to as little psychologists because they're more likely to gather and memorize as much information as they can on the social rules. They may, and they memorize this, and they look at, all the expectations. They may read books, study television shows or movies. They may mimic social behaviors of the characters they have studied. So this, this makes it difficult for us to realize, they do such a great job. We may not, always pick up on this because they're definitely, they do a great job even of looking at what their peers around them are doing and being able to mimic much more so than males. They also tend to be more aware of what is expected socially because of that. Again, this masking and camouflaging is going to continue to come up, and I'm going to talk about it more in depth later on. But they also, they mask or camouflage, those are interchangeable terms, so that they can fit in socially. So they hide what their challenges are. They're able to study what others are doing, and then they can hide the difficulty they're having so well, and they can appear to fit in. And that may, again, barrier. So they don't always exhibit difficulty with making friends either. So again, another area that we may think, okay, it must not be autism, they have friends. They usually don't have so much difficulty making friends. It's usually the intensity or the demands that strain the friendship that they often don't recognize. So distinguishing acquaintances from close friends, or defining what actually constitutes like a best friendship. They have difficulty with that. May be very possessive. They may expect a lot from their friend, and they may expect their friends to have only their friendship and not be friends with anyone else. And that makes it very difficult all around. Also, they maybe find less detectable ways to limit or avoid eye contact. So it has been said, in the research, but also, I've heard this from my female clients so often, that they just find a way to make eye contact is still difficult for them, but they find a way to still appear as though they're looking someone in the eye, but not actually looking them directly in the eye. They might look, at the forehead. They oftentimes, know how to kind of reduce their gaze. Like they won't have a direct gaze, but they'll still have a way to show the listener they are listening. What's being said in the conversation. But this is really hard. Like it's hard. They have to think about this all the time. So, so again, the social deficit realm is so much different for females. So, delving a little further or exploring a little more with females about, if these things are difficult for them, or how they view friendships and things like that, it can be really helpful to determining if they're having difficulty and what these relationships actually look like. The next section here is communication deficits. And so as I mentioned in the previous slide, girls on the spectrum often have been referred to as little psychologists. So again, studying their neurotypical peers allows them to mimic communication skills and styles. They oftentimes may adopt more passive roles in the communication. So they just kind of go with the flow, and they don't have to say a whole lot. They follow their peers. They may be overly careful in conversations and fear that they will upset someone. And this is something that comes up a lot in my practice with the females I work with. It's hard, oftentimes to have these conversations because so much thought goes into it. So they're oftentimes continually thinking about, well, what should I say? Is that going to be the right thing to say? What if I, upset someone? So that fear will actually cause them to not say anything when they want to take part in conversations, for fear of how the receiver or the peers might receive their message. They may be considered the shy or quiet one. This often happens in schools. It might be considered the good student who's always quiet and never complains or, just goes along with everything, but yet they're struggling, and probably have really high level of anxiety. And when social expectations become more complex, that's usually when the social communication kind of throws a red flag, but not always. So, again, being aware of how this might look differently. And sometimes this is like having a teacher, fill out an assessment, having parents fill out an assessment, getting a fuller picture. Maybe the female you're sitting across from doesn't even realize she's doing some of this. Okay, the next one is special interests. And as I mentioned in the beginning of the presentation, just briefly, special interests may be very similar to neurotypical peers. However, the intensity is so much different. Oftentimes this is another, red flag that we miss, because we may, hear a typical interest and not ask further questions because it's not throwing that red flag up. And so it's really, really important to look at, how they exhibit these interests, what the intensity is. And so I wanted to give an example here, just to help better understand this. So imagine a girl has an interest in Barbie dolls, and then this doesn't throw a red flag at first. But if you were to dig a little further, what oftentimes happens is, clinicians realize there's a huge difference in intensity and in even how Barbie dolls are played with. For example, girls on the spectrum may not actually play with the Barbies or allow anyone else to touch them. She might set them up in a specific way, and it would cause great distress if any of the Barbies, were moved out of place, or if peers came over and wanted to play with them in a typical way, that might not go over well. Barbies can sometimes take the place of friendships or, stuffed animals, stuffies. I hear a lot of my clients, share. Girls can actually form a connection with these stuffies or with the Barbies. And if they're lost or broken, there may actually be like a mourning of this loss. And, when parents will try to go replace it, that's not typically acceptable to them. So, and this isn't everybody. And when I say them, I mean, again, sharing what I experience in my practice and what the research has shown. Another example is that I see females that are much older than what you would typically see as an age that was interested in Barbies, yet they continue to be interested in Barbies long after their peers or neurotypical peers. They exhibit passionate but limited interests, may stem in ways that are different from what we equate with autism. So think about what I said in the beginning, the male model, has us think about, maybe flapping arms or spinning or, those behaviors we typically equate with autism. But in females, it can look so much different. So it could be skin or nail picking, hair twirling, hair pulling. I have, many of my female clients that will actually pull hair out. So it can look, so much different, as I, mentioned, earlier, that male model, the female phenotype looks very much different there as well. And the perseveration, so the perseveration that we often see, or think about with males, with females can often be internalized. So what I see a lot with my clients is that they have negative thought loops that they perseverate on. So it's like a constant perseveration of these negative thought loops that can lead to, depression. They'll replay events over and over, oftentimes, and perseverate on that. What did I say? Did I say something wrong? That just, there's a lot of things and anxieties involved, of course, as well. But again, kind of hiding from us because they're internalizing those. And unless we ask about them, we may miss that one too. So accompanying challenges outside of the three categories that are in the DSM-5, autistic females often struggle with alexithymia, and this is difficulty with emotions, but not like what we might think. So it's difficulty understanding and expressing their emotions. A lot of people believe that, well, all people, not just females and males with autism have difficulty experiencing emotions. However, they tend to experience very deep and often intense emotions. It's more likely that they have a problem expressing them. And there's an overlap between autism and a condition called alexithymia, which refers to the inability to describe emotions felt by oneself or others. So this is really important to consider because although it's not, a mental health disorder, it's really, difficult to, as clinicians, we're trained to do a lot of things around emotions and helping with things like emotion regulation, but you can't get to that point of helping with the emotion regulation until you address the difficulty expressing emotions or even identifying emotions, and getting in touch with emotions in a safe way so that they can express them during therapy and talk about things that they can do. I'm going to talk a lot more about that later in the presentation, these emotions, but also, understanding that if you suspect that someone has this difficulty with identifying emotions and emotions of others, there is the TASC 20, the Toronto Alexithymia Scale that you can use. Again, that, people without autism have alexithymia, but if you do suspect alexithymia, it's always good to assess for autism, because there is so much crossover here. And also confusion around bodily sensations connected to emotions, which is called interoception. That's another big area. So most people are able to notice feelings in their body with the help of this important sense called interoception. Our brains use the information about the way our body feels to give us feedback on what's going on. So like our brains let us know if we're nervous, if we're anxious, tired, sick, hungry. It's defined as a sense that allows us to answer the question, how do I feel? So if this is another area of struggle, then a lot of those therapeutic techniques that we use aren't going to be we're not going to be as successful with them unless we kind of build that foundation. And again, I'll be talking a little bit more about this later. Other challenges that females are difficulties they might experience, executive functioning, difficulties with the typical things that you would see, the typical executive functions like planning, organizing, motivation, task initiation. Also theory of mind, which means understanding the perspective of others. Emotion regulation. So again, the emotions come up and difficulty with managing emotions in a healthy way. Sleep is a big one as well. They may have difficulty falling asleep. They may reverse nights and days. This oftentimes it happens with adolescents and young adults as well, where they kind of they stay up really late and then they sleep really late the next day, and they have difficulty getting up if it's early, like for school. Important not to jump to a diagnosis of bipolar solely based on sleep irregularities. OCD tendencies are really common as well. Oftentimes clients don't meet full criteria for a diagnosis of OCD, but it's still important to consider because it is so common. So you might want to explore this with your females. And also they may Your clients may meet criteria for other anxiety disorders, such as social anxiety, panic disorder, or generalized anxiety disorder, which also need to be in the treatment plan. Okay, so now I'm going to be talking about masking and meltdowns and autistic burnout. Masking, again, so important because it prevents us from making a proper diagnosis and other things result. Autistic burnout, which I'm going to be talking about, and meltdowns, interrelated oftentimes. So masking and camouflaging, as I said, they are used, the terms are used interchangeably. It means the use of strategies to minimize or hide traits of ASD, and oftentimes seen in females. I see it in my male clients too. But in most of the research, and probably most times that you may have heard masking, is usually connected to females. Masking and camouflaging, again, as I mentioned, females learning to imitate body language and facial expressions and even conversational scripts. Masking and camouflaging has been described, though, by autistic individuals as being mentally, physically, and emotionally draining. Imagine the intensive concentration, self-control, and the management of their discomfort, how difficult that must be to do 24/7. They may mimic peers and watch from the sidelines, use their intellect to figure out the best ways to remain undetected. They'll study, practice, learn appropriate approaches to social situations. As I mentioned earlier, they're watching soap operas or studying TV or movies and characters, reading books. It sounds easy enough sometimes, if you don't think about the strategies and how much work goes into that. And more often than not, it leads to exhaustion. And I'm going to talk about that a little more in the next slides. It can lead to withdrawal, anxiety, depression. It can even lead to suicidal ideation. So important to recognize that while masking in some situations can be helpful, because we all mask to some extent, but having no break from that masking or losing one's identity due to that masking can be totally exhausting. And, it's not surprising that it leads to mental health challenges. I also wanted to note that an alternative compensation strategy that I see in many of my female clients is that they prefer the company of males because they feel the social dynamics are relatively simpler. So, they say, like, boys are more accepting, of accommodating their social clumsiness, or they don't use those terms, but they just say, there's not so much drama involved, and I just prefer hanging out with boys or men. So there's so many things that go on that oftentimes we're just not aware of. And we can't know what we don't know, but once we know, we can that can inform how we look at our female clients. And being aware of this masking is so important. And again, I'm because of how it leads to mental health conditions and eating disorders, substance abuse issues, and suicidal ideation. And with the suicide rates being much higher in the population of autistic individuals, particularly females, it's very important to do a suicide assessment if you're ever concerned at all. Always better to assess. The word of, I always like to talk about the term high functioning autism as well, particularly with females, because they do such a great job with masking. They oftentimes get this term high functioning or mild autism. A lot of people like to hold on to, the term Asperger's syndrome as well, which is absolutely fine. But it's important to know that that doesn't mean that they experience their autism mildly. It means we experience their autism mildly. They're having a really rough time oftentimes, and because they're hiding it, we think, okay, they have just some, think about that that spectrum I talked about in the beginning. They have just a little tiny bit of autism, but also oftentimes, they're really working hard to have reached the level that they're at and to maintain that level as well. So again, I put in here, we're not aware of what they're internalizing and what they're masking. Understanding meltdowns. So another big concern is with females is meltdowns, and it's not that males don't have them, and that's not the case. But today we're going to focus on what what this looks like oftentimes in females. And I wanted to read a quote first before I talk more about the slide. And this is a quote by an autism specialist who's a therapist and was diagnosed with autism in her 40s. She says, several of my clients have shared the criticism they received from relatives, friends, and partners when they have meltdowns. I recently went into total meltdown after being grabbed unexpectedly by a friend. I managed to get out of the situation and ended up outside banging my head until it bled. My husband was so embarrassed and critical of me afterward. So it's so important to understand that there's a huge difference between meltdowns and temper tantrums. So with our females, a meltdown can be an intense response to an overwhelming situation, and usually not within their control. So they can become completely overwhelmed by the situation and they can lose control over their behavior. And thinking about that quote I just read, nobody wants to bang their head until it bleeds. I mean, this is not uncommon to hear. And I hear this with a lot of my clients. And oftentimes their families and the people around them view it as a temper tantrum, trying to get their way or get something they want. And that's oftentimes not the case. So meltdowns are oftentimes linked to the sensory and emotional overload. It can come from being overwhelmed by emotions. And again, they're very good at masking this. So they may mask and mask and mask and not let on that they're having a difficult time. And then all of a sudden the meltdown happens. Also that difficulty with emotion regulation and the ability to manage emotions in a healthy way can, lead to this meltdown as well. So definitely important to, if you're working with females, you're most likely going to hear about meltdowns. It's just a part of their reality. But I'm going to talk about things that you can do that will lessen them and prevent them and help them recover from meltdowns later in the presentation. So the next thing I wanted to talk about is autistic burnout. And this is something that is starting to be recognized in research, although autistic individuals have been talking about this for many, many years. I guess the research is just starting to catch up. Autistic burnout is a state of exhaustion, emotional and physical depletion, and disconnection from self and environment. It usually has three core characteristics: chronic exhaustion, reduced tolerance to stimulus, and loss of skills. Executive functioning skills can worsen during burnout. Someone with autistic burnout may struggle with speaking, attention, even cognitive functions. NIH researcher Dr. Raymaker and her associates were the first to put together a clinical definition of autistic burnout that differentiates it from depression and occupational burnout. She and her team at Portland State University are now working towards creating an unambiguous definition of autism burnout and understanding of the implications and recommendations for people on the spectrum, their families, and for us clinicians as well. There's such a variety of factors that contribute to autistic burnout, in addition to masking and camouflaging, as I mentioned in the previous slide. It can be triggered by the demands and expectations of just living in a neurotypical society that doesn't adjust to their challenges, just navigating this world and always accommodating or understand that's not, accommodating or understanding always of neurodiversity. Other factors can be stress related to work or school, or difficulty in relationships, chronic pain or fatigue, lack of self-care practices, lack of support or understanding from loved ones and professionals as well. So something to, just have on your radar as well, that autistic burnout is a real thing. And, in the next slide, I'm going to contrast it to depression. There's a lot of overlap with depression, but it's much different as well. Okay, so depression versus autistic burnout. So autistic burnout is distinct from depression, although it can lead to depression, and it is autistic burnout is oftentimes more seen in are seen more often in our females. Though, again, important to remember that males can experience autistic burnout. So looking at the differences, as I mentioned in the previous slide, burnout is that state of exhaustion and emotional and physical depletion and disconnect from self and the environment. And depression, on the other hand, is characterized by persistent sadness, loss of interest or pleasure, and a range of physical and emotional symptoms. And depression can be triggered by a variety of factors, like life events or medical conditions, might, also include loss of interest or pleasure in activity. And again, that changes in sleep and eating patterns. Sleep, the key word being changes here, because looking at the baseline of what the sleep typically looks like, has it changed? And also feelings of hopelessness and worthlessness. And autistic burnout and depression are distinct, as I mentioned, but also share some of the common symptoms. Dr. Raymaker, as I mentioned in the earlier slide, she's identified 2 specific markers that differentiate depression from autistic burnout. And so she says, look for changes in sleep patterns and a loss of pleasure. So in autistic burnout, even though it could include not, a waning interest in area of interest, it doesn't in the same way typically as depression. But there's definitely more research needed. Assessment for autistic burnout is something that has been identified as an area of need, increasing the understanding of underlying causes, more information on how to prevent and recover from autistic burnout. And again, that sleep, the struggle with the sleep, really, really important to mention again that depression also has the sleep problems, but usually with depression, it's new. So again, looking at that baseline, whether your client is sleeping too little or too much, is also always important to consider what is their baseline. And especially when you're assessing for depression, because if you were to use a typical depression assessment, you might ask about sleep and not realize their baseline is difficulty with sleep. I'm gonna, before I go on to the next slide, I wanted to thank you for participating in this webinar and let you know to obtain a certificate of completion. You must fill out the form at the certificate of completion link provided in the email for this training. Please write down this code now because it will be required to receive this certificate. The code is CC022023. CC022023. ASD and co-occurring mental health conditions. According to research in the Journal of Psychiatry, about 32% of autistic women, as I mentioned earlier on, are hospitalized for a psychiatric condition by age 25. And by age 25, 77% have been diagnosed with a mental health condition. And according to the DSM-5, 70% of all individuals with autism spectrum disorder have at least one co-occurring mental health condition. And over 40% have two or more mental health conditions. Autistic females are much higher risk of receiving a diagnosis as well as being hospitalized when compared with males, as I mentioned. And also, as I mentioned earlier, research shows females are at higher risk of suicide. Masking, burnout, and depression have been identified as increasing this risk. Okay, so now I'm going to talk about how we can support females with autism spectrum disorder with all the things that I shared in the first part of my presentation. So the information on this slide is from Dory Zenner. She's a Canadian social worker who specializes in working with autistic females, and she's created a therapy protocol for autistic females called the INVEST model. In her clinical training, she talks about the importance of helping females feel accepted, understood for their journey to diagnosis. She talks about how females may feel, coming to therapy provides a clinician an opportunity to help females feel accepted and understood for the first time. Acknowledging all the difficulties they may have experienced on their journey to a diagnosis. The self-acceptance is so important. They may have always felt, like they didn't fit in, odd, weird for their entire life until they get the diagnosis and have some understanding of why they felt this way. And she talks about how being told to be quiet or be quieter or you need to fit in, you need to keep it together, can cause high rates of anxiety among other mental health challenges in our females. She also talks about changing anxiety, and it's important for clinicians working with females or males with autism to really understand this concept, because it's important to share with parents what this means. So change anxiety can lead to meltdowns if not addressed. So there's many reasons to make sure this is on our radar as well. Even simple changes in routine for autistic individuals can cause a high degree of anxiety, even when it's something positive. And oftentimes with my clients, it's something, a change in their life that they've always wanted. It could be, even, going to an art class or something they were looking forward to, but it changes their routine. So it's going to bring anxiety on, and that anxiety can be pretty high. So the same as with something negative that would cause them anxiety, some of the, these positive things can cause it, but also even minor changes in routine. So having that on all our radar, whether it's in the school setting, the home setting, or the clinical setting, it's really important to address that. And also to think about the impact of the late or misdiagnosis that may have caused an overall loss of identity for females. So making sure that we consider this when we're writing a treatment plan or when we're working with females. Energy accounting systems, which are a metaphor describing the amount of physical or mental energy that a person has available for daily activities and tasks, and how it can become limited for individuals with autism, can be super helpful, not only as a way to manage energy level, but also as an autistic burnout and meltdown prevention strategy. So you may have heard of the swoon theory before. This was created by Christine Miserando, and she used it as a way to express to her friend how it felt to have lupus. She used spoons at a restaurant to represent units of energy that a person may have, and then she reduced or took away the spoons, showing with a chronic illness how she's forced to plan out her day because she doesn't have unlimited energy. This theory has since been used to describe a wide range of disabilities and mental health issues and other factors that might place an extra burden on people living with them. So this is so super helpful. It has been for my clients. Also, there's a energy accounting that was created by Dr. Tudal. It's in the middle here. And autism expert, Dr. Tony Atwood, is called the theory of energy accounting. And it looks at withdrawals and deposits of energy. So if I didn't sleep good and I'm facing a full day, what do I need to do so that I can get through that day? It looks at how energy can be added, like breathing exercises, listening to music. There's a lot of different things that can be done. I use energy accounting systems with most all my clients on the spectrum, and we carefully create a plan of how many spoons of energy they will need to use in a day, particularly when an unplanned event is coming up. And we look at ways that they can be sure to make those deposits so they don't run out of energy in the middle of the day. And it's so important and very individualized to look at ways that energy can be added back in. As I mentioned in the beginning of the presentation, and I brought up several times, emotions is a big thing and common for people to think about. Again, think about individuals with autism as not having emotions, but it's more about difficulty experiencing their emotions and keeping in mind their emotions can actually be very deep and intense. So how we use our typical therapeutic protocols, taking into account that we may need to build a foundation first to help with these charts are some of the things that I use with my clients, helping clients when they're feeling overwhelmed, by their emotions, to even begin to understand what the emotions are that they're feeling. And, these charts where you can, like SUD scales, where you can help them identify and link, as I mentioned, the interoception, the body feelings to, like on these such charts, like when I'm at a 2, I might or a 3, I might start to feel my heart pound a little. That means I'm probably anxious. So, having a way to just help them begin to understand their emotions better, it can be so impactful. And knowing how their emotions impact them, 1 to 5 scales, 1 to 10 scales, what behaviors they exhibit when that happens, tying the emotion to the behavior. There's a lot of different things that can be done here, but going straight into maybe CBT, where you're already connecting your thought to your, feeling to your behavior, sometimes is difficult without this foundation. Supporting females with regard to meltdowns, but also I wanted to mention here the CAT-Q, which is the camouflaging autistic questionnaire. If you notice that your client is masking or suspect that they may be hiding their autistic or autism traits, you may want to consider using this CAT-Q. It's a self-report measure. I have the website here where you can find it. It's at embraceautism.com. So it's a scale for adults, but if you are working with children or adolescents, you can still look over what the questions are and determine if you want to adapt them into maybe your intake, or even the questions you might ask, that if this comes up and you are concerned that masking is going on. So I've talked about several times already about meltdowns and what a big problem this can be for our females. Important to consider addressing this in therapy. So some of the things you might want to consider is exploring triggers, tools. Crisis planning is really important because meltdowns are going to happen. So if you have a plan for them, it's really helpful. Meltdown recovery. What do you do after a meltdown that will help you recover from it? So important, to mention here that many of my clients might not know the term meltdown when they first come to see me. I usually hear from my clients and their families that they're experiencing panic attacks or anxiety attacks, they'll call them, and they'll also say that they've tried everything and nothing helps. So if you suspect autism in your female clients or even your male clients, and nothing's working, typical protocols, considering exploring further what these panic attack looks like, and consider, while some of the typical tools are still helpful for meltdowns, such as deep breathing, it's usually not enough. So some of the things I talk to my clients about that seem to be helpful for them is, they might have a quiet place in their home. It's usually in their room where they'll go to recover. They might use a weighted blanket, and they might use sensory deprivation, no light, no sound. We might talk to their parents or their families, excuse me, about giving them a little time and space to recover. This isn't helpful for everybody, but a lot of my adolescent and young adult female clients, they just need a little downtime. They're not ready to, excuse me, discuss, with their parents yet what's happening until they can, they can recover a little bit. And this is, an important time to maybe include, loved ones or family members, to let them know what, because, I include myself, with my own children, I tend to want to fix things or jump in and find out what's going on. And sometimes when it's a meltdown, that's the worst thing you can do. You need to wait until afterwards. So just knowing what's going on and being able to address that with your female clients, but then also to share that with their families, that, they can try, like, just giving them a little bit of time and space, and then having a plan to regroup, once they're in a better place or they've recovered. Also really important to come up with an exit strategy for when your clients aren't at home and they can't go into that, their room and use their tools. If they're feeling like they're getting to a place where they might have a meltdown, what kind of exit strategies might they be able to use to remove themselves from the situation before the meltdown happens? I put up this tips for preventing meltdowns on this slide. Livedexperienceeneducator.com is where it came from. There's some really great tools on that website. They all come from an adult female who has autism and had a late diagnosis. And so hopefully you can explore this and use it with your clients. It gives you, kind of walks you through some things that you can do with females and with males as well. Like I said, I want to focus on just females, especially with meltdowns. I see that equally with males and females. So hopefully this will be helpful to use in practice. They're really easy tools to use. They outline how to create the exit strategies. They outline how you can create a sensory toolbox, just a wealth of information here. So other ways that we can support females, we can focus on helping them build their self-esteem and self-acceptance of their autism. This sometimes, as I mentioned, can be difficult in adolescents and young adults. But we can follow their lead and work on these things, slowly and adapt them to where our clients are. Focusing on strengths is so important. There's many gifts and strengths that females have, and focusing on these can be so important. It can also help socially. So for instance, if someone is an artist or very interested in art or dance or whatever it may be, attending a group or being involved in school that gives a common interest that is already there with other people that they're interacting with, and oftentimes this makes it easier socially. So the strengths that's so super important. Always consider incorporating an educational component into the therapeutic process, just to help females understand autism and how their autism impacts them. Again, and I know I mentioned this, but thinking about an adolescent and or a young adult, and thinking of just hearing this autism diagnosis at that age, how difficult that might be, and to help normalize a little bit, they're not the only ones. There's 1 in 44 that have autism spectrum disorder. It, doesn't necessarily mean it's going to hold them back from any of the things they want to achieve in life. It's just information on how to best support them to meet those goals. Things like that can be really super, helpful. Adapting mental health therapy protocols. This is a big one. Making sure that all of us, that we understand the difference in thought style, how an individual with autism might handle information, how it might process it. Oftentimes, like, retrieving the processing could be a little bit different, or sometimes slower, sometimes not, but considering that. And also sensory differences, trauma impacts that individuals with autism deal with all the time, stressors that are unique and common to autistic individuals, as well as something else to make sure we consider. was common for autistic individuals to find it difficult to comprehend information from another individual's perspective. So they can get quite frustrated when they're not understood, or they don't understand others, or understanding how people might think very much differently. This can create difficulty socially, emotionally, and even with communication between a client and a therapist. So remaining aware of those things is really important. The theory of mind challenges that I mentioned a little bit earlier on, this is the perspective taking or understanding emotions and actions and reactions of others. So, keeping that in mind. The central coherence weaknesses, this is understanding the bigger picture. Oftentimes, our clients with autism can get stuck on the details and may, instead of seeing the big picture, stay focused on the details. You may hear this described often as missing the forest for the trees, but they may be so focused on a single aspect or detail of what we're talking to them about, and they may miss the central idea or the big idea of what we're trying to help them with. Providing instruction on utilizing skills in different environments. Generalizing skills is so important. So oftentimes my families will say, well, I know my daughter, knows how to do this at home. Why can't she do it at school? Or she can do it at school and she can't do it at home. Or so it's really important to know that just because you teach skills or help support your female clients or even your male clients in one environment, like if they learn it in therapy, it doesn't necessarily mean they're going to know how to use it in all the different environments that they're going to encounter. So, thinking about providing instruction in different environments, and homework is really helpful here. And that's, not a word I like to use with my clients, but just giving them things that they can try out at home and then come back and let you know how it worked. To know that, and even having parents provide feedback on how something went that they tried, can give you information on whether or not they're able to generalize what you're asking them to do. Encouraging females to read books and view videos by autistic girls and women can be so empowering for them. Hearing, how successful other girls and women are, and to really give a female face to this, because, I'm talking a lot about what this extreme male brain has caused a lot of us clinicians to view autism. Imagine being that adolescent or young adult woman who gets the diagnosis and then starts to extrapolate what she's maybe read or seen as this male theory. So it's really important to provide that perspective and give her that lens as well. And there's just a wealth of wonderful videos out there that are so helpful. Helping her find where she fits in. There's a lot, there's a lot outside of what our typical mental health kind of view, therapy view might look like. And some of these things that are helpful to females don't always fit in within what we've been taught. So, considering some of these things and if and how they might help your clients is so important. So oftentimes, helping a female find a place she fits in, or we call, you may hear this a lot, finding her tribe, is so helpful. Attending a support group of females with autism can be helpful. Not all my clients will agree to that, but it can be super helpful and empowering, for any of us to feel understood and know we're not alone is so helpful. Social activities based on area of interest, as I mentioned a little bit earlier, if it's art or dance or something that that she's already has a strength in or an interest in. It makes it a little easier with social interaction, built-in topic of conversation, helping identify difficulties with boundaries and recognizing own limits is really important too. So oftentimes females and with or without autism, with or without autism can oftentimes be people pleasers. Even more so when you consider female with autism, and also like you're thinking of the masking and everything else that can come along with it. She may try to say yes to everything and people please, those around her, and to her own detriment. So helping her understand that boundaries are healthy, they're not mean. I mean, a lot of my clients, my female clients, will say, well, I feel like I was mean, or I was not a, good friend, but, learning how to set those boundaries will not only protect, them, but will also limit the chance of a meltdown occurring, because it's usually when you're doing too much and becoming overwhelmed that you're more susceptible to having a meltdown. Also important to recognize that females are at higher risk of victimization, and they don't, teaching safety explicitly is so important here, whether or not it's, online or in person. That oftentimes females really need to hear, what these safety rules are, because they may not have picked it up along the way, and that they are more at risk because of that. Incorporating that, if you feel that there is a safety issue, is important. Also, as I mentioned, the increased risk of mental health conditions and suicidal ideation, always assessing, especially if there's any suicidal ideation involved. Dr. Jack Scott, the executive director of FAU CARD, has a training on the FAU CARD YouTube channel that focuses on, what do you take into account if you're assessing someone on the autism spectrum for suicide. So please refer to that if you want further information. And online friends and support are very common and can actually be helpful, for both females and males, but we have to be really careful, and we have to, talk about safety issues with social media and, joining like online support groups, because oftentimes both our females and males can be taken advantage of. Awareness of the increased rates of bullying and teasing, and even being excluded among females is something, that happens quite frequently, and something that might need to be addressed in therapy as well. Also appreciating the effects of autism on the entire family system, because it usually doesn't just affect the individual with autism, but it impacts the entire family dynamic or system. So considering that too, because, oftentimes I'm working with families who are in and out of crisis. And when I say crisis, I don't mean they're calling 911 all the time. Rather, they feel their family is in turmoil and not functioning well. Oftentimes I'll hear, my parents say, I can't do this anymore. I don't know what else to do. And that, that affects everybody in the family system. So, if you're just working with your female client, yet the family's kind of in and out of crisis like that, it's helpful to consider if you're working with a female adult, with her permission, and also your adolescents, with is it okay that I share with your parent that we worked on meltdown prevention, so they know what they could do that will help, things like that. Very, very helpful, at least in my experience, to provide that education to the parent, caretaker, and family member who might be able to help, kind of like be that coach for their daughter outside of their session. So, you know, just super important to consider. Also consider working as a team. So, you know, the psychiatrists that my clients see, I'm, you know, checking in with them frequently, you know, what medications are, you know, are you prescribing, why, you know, the schools, like, are there other accommodations that might be helpful, because you're seeing them, you know, from a different, you know, lens, you know, that you might be able to provide more input. In addition to family, just considering, like, how do I build a support team, like a kind of like a wraparound support team for my female client, because many of us mental health providers, we only see our clients for an hour a week. And so what might they need outside of that hour that you can either team with or help provide resources and referrals to some of these team members if you see that there is a need. All right, that is my presentation. I, you know, want to thank you again for attending. I hope that you found some or all of it valuable and helpful. And I just really appreciate this opportunity to talk about females. And I'm really, I think it's really important that FAU card is focused on this underrepresentation of females with autism. So thank you again. I have a couple resources here for therapists. And if you, hopefully you'll look to more PEPSA trainings. And there's been a variety of trainings done by PEPSA and FAU card that are focused on females. There's more basic trainings, there's parent trainings, there's trainings that are focused on diagnosis alone. So I hope that you'll check out the FAU card YouTube channel and the other, also the PEPSA website for more of those resources. Thank you and have a great day.